So I want to introduce our next presenter is Dr. Charles Berul, who is a pediatric EP at Children's National in Washington, D.C. Although I think he's traveling right now, right? You're not in D.C. today.
I am in DC. I'm back.
Oh, you are back.
Yeah.
Great. So Dr. Berul is going to talk about the future of ICDs and what's on the horizon.
Great. Well, thank you all. Hope you've had a good day so far, and thanks for joining and sticking it out till close to the end. We are going to talk a little bit about ICDs, what's on the horizon, and we're going to talk a little bit about the unique aspects of children getting ICDs as well. We know that children aren't just small adults, and if you put an ICD in a baby this size, you have to plan in advance for them becoming larger adults. And so this needs to be begun at the beginning, because the devices aren't designed for children. And if you look at these three photos, the premature baby with the giant temporary pacemaker, the infant with a midline scar to put in a pacemaker, and this cute little ballerina, the arrow pointing to her abdominal device, defibrillator that's there in her belly. Again, these are used with the parent's permission. You can see that these devices aren't specifically designed for children. Now, ICDs have come a long way. These are two examples. If you look at the X-ray on the right, you can see a lot of leads there, a lot of junk in this young child. You can see epicardial and endocardial leads on the X-ray. In the stomach area over here on the patient's left, there's a pacemaker and additionally a very large defibrillator. And so that's how we had to put them in. ICDs have come a long way in a relatively short period of time. If you look at that nice plaque that was given to one of my earliest patients, in 1994 at age 10, she was the youngest recipient of a defibrillator at that point in 1994. We've come a long way. She's come a long way. She's now a mom with kids of her own. While she's outlasted that company. The company that designed that pacemaker, Telectronics, has gone out of business, and she's still thriving. Now, this was just published, and so I just wanted to show this expert consensus document that just came out in the last week or so from the Pediatric and Congenital Electrophysiology Society. And it's rare to have unique, specific guidelines for the management of defibrillators and other devices in pediatric patients. And they come up with guidelines that are green, orange, and red, kind of like a stoplight, where green is where the expert consensus is there's general agreement to put the device in. And in general, for implantable defibrillators, usually survivors of sudden cardiac arrest due to ventricular arrhythmias, unless there's a reversible cause. And for the yellow light, ICDs can be considered for patients with sustained ventricular tachycardia that can't be adequately controlled with other modalities such as medications or ablation. And as well as for primary prevention of sudden cardiac death in patients with genetic cardiovascular diseases and risk factors, such as many of you on this symposium today. And it even breaks it down by specific diseases. When should people with long QT syndrome get ICDs? And as many of you know, ICDs aren't recommended in everybody with long QT syndrome. In fact, it's the minority of people with this diagnosis who should get an ICD. Most of patients with long QT syndrome can be managed without a defibrillator. I won't get into the details of each one, but at least for long QT, survivors of sudden cardiac arrest is typically class 1 indication, meaning general agreement, or in patients with symptoms in whom beta blockers are not effective or not tolerated, and other medications aren't considered effective. And then the yellow light, class 2, ICD therapy can be considered for primary prevention, meaning before having an episode in long QT patients with established clinical risk factors or more pathogenic mutations. But it's not indicated in asymptomatic long QT patients who are deemed to be at lower risk of sudden cardiac arrest and have not been tried on beta blocker therapy. And I think most of you know that. There's similar guidelines for CPVT, and similar guidelines for Brugada syndrome. Again, the vast majority of patients with these inherited arrhythmias aren't recommended to get an ICD. And so if you go to your doctor and they say, well, you definitely need an ICD, make sure they're going by the guidelines or get a second opinion. So what's new, because that was my task today, was what's on the horizon. And we're going to get into some of the things that are recent and then things on the horizon. So the ICD generators, the actual battery pack and computer chips, haven't gotten that much smaller. They have gotten smaller in size, but not that dramatically over the past decade. There's no real market incentive for miniaturization because children are only 1% or 1 in 100 of the defibrillator market. And so there's not a business case to be made to make a miniature defibrillator. Now, the battery and capacity technology is improving, and so you could develop a miniaturized pediatric defibrillator. This is to tell you that the leads, the wires, are the weakest link in the system. The generators are very reliable. Most of them do really well, but the leads are the weakest link. And so we've asked to make the leads thinner for smaller patients because we see this problem a lot. This is an X-ray showing venous obstruction. There's some X-ray contrast material going through the vein in the arm. And what you see up in this middle part where the white arrow is that the contrast material, the dye, doesn't go into the heart because it's all blocked from having a defibrillator here. And that's, the smaller you are, the more common that becomes. It also becomes more common the more leads you have through the vein. And so it's a reason not to put too many leads in transvenously. So we have had pleaded with the companies to make thinner leads, which they did. But then we learned the hard way that thinner isn't always better. On the top, there's two ways to make the leads thinner. One is to put less insulation, the polyurethane and silicone, between the conductors. So if you put less insulation between them, the leads can be thinner. But turned out that in some of this, in this situation, there became electrical noise that we saw on the leads. And the defibrillator saw that noise as possibly a ventricular arrhythmia and caused inappropriate shocks. And for those of you that are on this call that have defibrillators, if you've ever received a shock, it's great if it's a life-saving shock. It's not so great if it's an inappropriate shock if you're just sitting around doing nothing. And the other way to make the leads thinner, besides having less insulation between the conductors, is to have less insulation outside the conductors. And this is what happens here. You get extrusion of the conductors outside of the insulation. They break through, and those leads fail in a different way. And so both of these types of thin leads are now off the market because of a higher failure rate than the standard thickness leads. And I alluded to the fact that you have lots of leads in place. If you think about it for young patients, whether they're children or young adults, we hope to get decades of life after putting these defibrillator leads in, and the leads don't last more than maybe 2 decades. We're happy if a lead lasts 20 years. On average, it's probably less than that. And there's several options. What do you do when the leads break or are no longer functional? Well, you can abandon them in place, but it's probably not a great idea because the more junk you leave in there, you're just kicking the can down the road, and eventually they're going to need to be removed. There's the manual traction method, basically just pulling until the lead comes out. I call it the big jerk method, and you can interpret that in a couple of different ways. In the old days, which was only about 30 years ago, you used to admit the patient and use weights and traction until it pulled out, and eventually the lead would pull out. And nowadays, usually some powered extraction tools, either a laser sheath that you see here on the left, where a ring of light will cut through the scar and free up the lead that might be stuck down. The middle panel is a radio frequency lead extractor that burns through like cautery to get the stuck lead out. And then the third one is one example of several different mechanical tools that cut around. I call it the apple coring method. It basically looks like one of those apple corers that frees up the lead using mechanical force. Lead extraction in children requires a lot of pulling and tugging. And my adult electrophysiology colleagues tell me that it's a lot harder for them to take leads out when they're put in as children, even if they're extracting them when they're young adults. And sometimes you think of that, I think it's a Bonnie Raitt song, Take a Piece of My Heart. If you look at that lead coming out, there's a little piece of heart beating on the end of that tip. And so we have to be careful when taking out leads. Lead extraction is riskier than putting leads in the first place. And so you need to plan during the implant for what are you going to do during the extraction. And there's risk of abandoning the leads in place. There's risks of infection or problem with the valves, and there's risks with extracting the leads. And so you have to balance that risk with the benefit and make a decision whether to take the lead out now or kick the can down the road and take the lead out in the future. But in general, for the future, I think the goal is to avoid putting leads in veins so we don't have to worry about taking them out, the risk of lead extraction in the future. Well, lead extraction has gotten safer and better with new technology. It's still a relatively risky procedure compared to implant. And so the future goals, what's on the horizon, is defibrillators without leads in veins. Now, this isn't even the future. This is 20 years ago when 3 different groups first reported this idea independently. I was one of those groups showing a defibrillator that's a similar concept as an external, an AED. Think of the patches that go on the side of the chest. Well, you could put a lead just under the skin on the side of the chest and put the defibrillator in the belly. And my group reported this 20 years ago, as did 2 other groups, one from Denmark and one from Germany. And we all had the same idea without even talking to each other, all published in the same year. That was 20 years ago. And none of us were smart enough to patent it. So other companies came up with similar ideas. This is the other way to do it, to have the surgeons place the leads. The one that you see moving now is a pacemaker lead that can get screwed in to the outside surface of the heart. And then on the left side of the screen, you see a defibrillator lead, a coil that's being snaked in behind the heart to place it directly into the pericardial space, the sac that holds the heart. The coil for shocking goes behind the heart, and the defibrillator goes again in the belly, so that you get a way of placing the defibrillator without putting leads in the veins. These are, still relatively invasive procedures compared to transvenous approach. So there's 4 ways of putting defibrillators in. The transvenous approach through the vein, if the child is big enough. Here's the can, it goes through the vein. This is the way the vast majority of adults get their defibrillators placed. And there's the ICD coil in the right ventricle through the vein. And that's by far the most common. The epicardial approach, where the surgeon opens the chest and puts patches on the outside, is pretty much outdated now. Very few people, children or adults, get this approach. The subcutaneous approach, what I just described, putting a lead or array here just under the skin. And then this pericardial coil, which I just showed you the video of. That's what it looks like on the x-ray, the coil going behind the heart. Those are the 4 routes of putting ICDs in. Now, the subcutaneous ICD has now been out about 10 years and has no wires in or on the heart. And it's similar to what the concepts were that were reported 20 years ago, but this got commercialized by a small company. And what we see here, many of you have known this, this is the can that goes in the underarm, in the left underarm, and then the wires just under the skin, below the ribs and along the sternum or breastbone here. So there's nothing in or on the heart. And that's exciting because here's a commercial product that may avoid putting leads in the veins. It was pretty big when it first came out. Here's a 10-year-old little boy with hypertrophic cardiomyopathy, weighs 32 kilograms. So that's about 70 pounds or so. And this is what it looks like cosmetically. You can see it sticking out there in his left underarm. It bulges out, and the scar is pretty big. But again, it has those advantages of not having anything in the veins. So you don't have to worry as much about extraction or infection of the heart. If it gets infected, it's at least all subcutaneous. And this is him playing video game with his brother after implant. And we see, those who can read electrograms know that this is ventricular fibrillation. It lasts about 25, 26 seconds, and then he gets a shock here, that little lightning bolt that you see. He gets a shock and shocks him back into normal rhythm. So a successful shock, but it took 25 seconds, which is a long time. Not so bad if you're a 10-year-old playing video games, but a little bit more concerning if you're a 30-year-old on a ladder or driving a car. The version 2 is better. It's new and improved. It's a bit smaller. You can see it's thinner, less volume, less weight, and lasts a little bit longer. So it has those advantages, and that's great because version 1 was pretty big, as I showed you, but this is still big. And so we can't really use this in the smallest of patients yet. This is one that I implanted maybe a year ago or so. And we typically, in patients who don't have a lot of soft tissue or padding, will put it not subcutaneous, which is how it was designed, but submuscular. So it's a little bit more of a surgical dissection to get below the muscle. But once it's there, there's more padding there. Although there's a little bit more, quite honestly, discomfort or pain for the patient as they recover from that procedure. And you have to customize them, like we often do in children. Here's a report that shows where they have to bend or bow the coil. You can see on this x-ray where they're bowing the coil to have it fit in the small chest of a child. And in this child who has dextrocardia, meaning the heart's on the right side, it's not the x-ray is reversed. They place the device on the right side of the chest instead of the left side. If the heart's on the right, the device goes on the right. So things to think about that are unique in people with congenital heart disease. And there are still problems with these devices. The main issue is inappropriate shocks, getting shocked when you don't have ventricular tachycardia or don't have a life-threatening arrhythmia. The top is shocking for someone with supraventricular tachycardia, which may be fast but is stable and usually not life-threatening and can be treated with less uncomfortable options. And the bottom is inappropriate shock for what's called T-wave oversensing, where the device double counts. It's counting the heart rate twice what it should be because it's counting the normal QRS and the T wave that follows it. And so patients really hate getting shocked when they don't need to. So sometimes you have to be creative, and we have to customize things and not just use them out of the box. And so now I'm going to tell you some of the things that the title of the talk is things that are on the horizon, doing things creatively for these patients. So here's a pretty novel idea. This is substernal defibrillator. So the sternum is the breastbone. And so substernal is a coil that is placed with what looks like a knitting needle, is really what it looks like. And it goes under the breastbone and right under that space, and what's called the substernal space. So between the ribs and the heart. And so that's been in trials now. And this is actually a human trial. So they've been doing this in 20 adult patients, this first report, showing this actual device in the substernal, extravascular, meaning not in the vein. Again, that's the advantage of this kind of device, is not being in the vein. This one I found really exciting when I saw this presented about 3 years ago. I haven't seen anything since, and I've checked the literature and haven't seen it commercialized or anything, but it was exciting when it was reported, the subcutaneous string defibrillator. That's what it looks like, a string with what looks like maybe a water balloon that goes down in the belly and around the heart like that, just again, all in the subcutaneous space, so just under the sort of fat and above the muscle and above the ribs. This would be very exciting if you could put it in this way, but I haven't seen it further. Maybe they're awaiting more trials. In the last few minutes, I'm going to talk about some of the work we've been doing over the past decade to try to develop a minimally invasive percutaneous, meaning through a small port or needle, pericardial defibrillator placement. So sorry to those of you who aren't in medicine to show pictures of piglets, but that's what we use. Piglet and a baby have exactly the same heart anatomy. So here we're comparing on the left with an open chest approach, which is the standard approach to sew the lead on. The surgeon has to do a thoracotomy, meaning open the chest, just to put those two sutures on, just to sew the lead right there. So that's a lot of surgery to make 2 stitches to hold the lead in place. And so that's why I've been working so hard to try to be able to develop it to just go through a little port like this. So here's what the port looks like in a piglet. You can tell it's not a human. There's 8 nipples, so not a human. And this port has 2 holes, 2 ports inside. Through one of them is a thoracoscope so that we can actually see what we're doing with a little tiny camera. And through the other hole goes the defibrillator lead. And then we take the plug out and the lead stays in place. So here's a video of what this looks like from the inside. Here the needle's going through, and you can see the heart beating. And it goes into the pericardial space. Again, that little sac, fluid-filled sac right around the heart. And there's a soft wire that goes around, wraps around the heart. The needle's out now, just the wire's in. And then a plastic sheath goes over the wire. Once that sheath is in, we can place the ICD defibrillator lead through there, and you can see where it's being fixated, where it's being attached to the heart with a little screw, and you can see where the arteries are to avoid placing there, and then you remove the sheath through a little tiny hole in the pericardial sac, which is fine, and that's really the whole procedure. So we're excited about this, and we hope to get this to human use, and we've even trying to downsize it. Again, everything can be miniaturized. We thought we miniaturized it enough with those trials, and now without even a port, it's just a needle stick, and the needle just goes under the sternum, and the picture of the finger there, that little black rectangle is the camera, and that camera goes at the end of the needle so we can see what we're doing and get those kind of pictures. So when I was growing up, it was my favorite TV show was The Bionic Man. The $6 Million Man was the 70s TV show where he got rebuilt after, I think, an astronaut accident. And so like that, we can make a better defibrillator. It can be smaller, flatter, smarter, and longer lasting than the current devices. And we can get it down to a miniature size, and it's within reason. ICDs have come a long way since they first came out. And so we can certainly imagine within the next decade an injectable ICD like this. You have to be creative. 50 years ago, this is how we all watched TV. They were big, clunky console devices, black and white. Nowadays, you're all watching on your phones, color, high resolution, and miniaturized. Here's an ICD from 1988 to 1990, one of the earliest defibrillators out there. It was big. And so it's only been 30 years. There's a lot of technology, and it is very reasonable to imagine to be able to miniaturize this even further to get it down to the size of a port, or even to be able to inject it through a needle. I think that's very reasonable. So I want to thank you all. ICDs, even as they currently are very reliable and life-saving. And so those of you who have an indication for a defibrillator, I strongly recommend them, and I put trust in them. And we are just trying to make a good thing better. Happy to take any questions.
Thank you, Charlie. We have quite a few questions already posted in our Whova platform, and so I'm going to read some of those, and folks certainly can add more questions in the chat field, which actually Charlie can view those for sure. Why don't we start with the ones that are here in the chat? Regina asks, are there options to have an extravenous ICD with pacing capability for those who require either atrial pacing or ATP?
Well, that's a very informed question. And I think right now that's really the rate limiting step of extravascular defibrillators, is that they aren't great for pacing. They can provide emergency pacing, but for people who need pacing much of the time, or pacing for low heart rate, or for resynchronization pacing, what's called CRT, they aren't quite there yet. So it may need to be paired with something else, with some sort of pacemaker, either the way that we were showing them, with pericardial placement into the of a pacing lead that way, or a leadless pacemaker. I talked today, my presentation today was on defibrillators, so I didn't talk about leadless pacemakers, but it's certainly imaginable that you could pair a leadless pacemaker with a subcutaneous ICD, just like you pair your phone with your watch or something like that.
Okay, from Huva, when would old leads be removed, if at all?
So that's always a debate. And I've often been asked at some of the national meetings to give the pro and con of that. And I've presented both sides. This is my personal belief and recommendation, is that you can probably leave one pacing lead in place if it's not infected. But I wouldn't abandon more than one lead, and I wouldn't abandon a defibrillator lead, because they can bang against the other lead and cause electrical noise. And eventually it's going to need to be removed. And so the longer you wait, the harder it is to get out. So unless it's a single non-functioning, non-infected pacing lead, I would suggest removing it, but being careful that you're having that done at a center that is comfortable doing lead extraction, which is a smaller group of experts than those that implant pacemakers. Does that answer the question?
Yes, you did. Thank you. Okay, let's move up. Are there any updates regarding smaller devices for ICDs?
Yeah, they've gotten a little bit smaller, but not that much smaller. When we change out ICDs, people, all the different companies are talking about their devices a little bit smaller or a millimeter thinner than the competitors, but they're all still about the same size. And so I'm not sure that they're going to get, I hope they are going to get smaller as battery technology and capacitor technology improves, and you can get these flat batteries instead of the hockey puck kind of devices that many people had and still have. They are definitely cosmetically better now than they were 10 and 20 years ago, but they're still, they're still a lot bigger than pacemakers.
Okay, thank you. Here's a question. Will we as patients ever get the ability to view the data from our ICD, like via a smart device app?
That's a good question. I don't know. I don't see why not. I think it's your data. You should be able to see it. I don't know what the regulations are. I know the companies are very proprietary about their data. They often won't share their data with others from a big data standpoint, and comparing big groups of people. But I think as an individual, it's your data. You should have access to it. If the argument is, well, maybe you won't understand it, that may be true depending on the person, but you still have, I would think you have the right to see your own data.
Okay. Are there any new battery technologies for the pacemaker ICD, specifically regarding the length of battery life and the ability to possibly charge your own device?
Yeah, over the years, there's been lots of great ideas. Most of them haven't lasted. The most interesting one were nuclear powered devices that lasted about 80 years. And most patients didn't want them. They were afraid either they could leak and get it, have a nuclear, have a radiation exposure, which was pretty unlikely. but people were very hesitant to use them, and they stopped making them. But they would last 80 years. So the technology's been there for forever, but nobody wanted a nuclear powered pacemaker. There's some that are rechargeable. The technology is already there for rechargeable pacemakers, but the companies have been hesitant to rely on trusting the patients to recharge. Whether it's, I've seen lots of good cartoons about solar powered pacemakers with hats with the solar panels on them, but I don't think that's a reality. But charging, ultrasonic charging, like you wirelessly can charge a phone on a platform or in your car, is a reality and could be done. One of the other arguments that people make is because these devices have so much technology in them, maybe you don't want them for more than 7 or 8 years, and I think that's a manufacturer's business plan, right? Many people don't keep their laptops more than 8 years because they become obsolete. People change their phones every 3 years or so. My kids change them every 2 years. And so that's an argument that companies make, but I think that's because they want to keep a business. If they only sell you one device over 80 years, that's not a very good business plan for them. But yeah, so the technology is there, but there are concerns regarding the safety of how compliant you would be in terms of remembering to recharge. It's not just a Tesla.
Mm-hmm. Okay, what are the different implants of an ICD?
The different implants, meaning how can they go in? You think that's what?
Maybe the different types of implants?
Yeah.
Let's see.
I mean, it's either on the inside of the vein, which is 90% of defibrillators, maybe even more, are put in through the vein. And then the few percent are that the ones that go on the outside, either surgically placed, often during the time of another type of surgery, either having a bypass surgery, and they put the leads or wires or patches on the outside, or congenital heart surgery. At the time they're doing open chest surgery is often the most common situation where leads are put on the outside of the heart. And then the third way is the extravascular way, either subcutaneous being the only commercially available one now. The ones I've shown that are either pericardial or substernal are all not approved ways. They're all currently in trials or are done off-label. Sometimes you need to do it with off-label if that's the only way you can get a defibrillator in.
Okay, let's see. When can an ICD be implanted? An age or a weight or what? Our daughter-in-law has one, but wondering when our grandson, who's 3 months, can get one. Yeah,
we put them in 3-month-olds, but only in very serious situations. I think we wouldn't put, again, it's in your specific, I'm talking in general, I'm not talking specifically about your grandson, right? I can't give you medical advice specifically about your grandson, but we have certainly put them in 3-month-olds or less if they've had a cardiac arrest or something like that. Even younger than 3 months, they have to be put in the pericardial space, open chest by the surgeon at this point in time, not the way I showed you in the piglets yet. That's not approved, and not the subcutaneous ICD. But open chest surgical placement of a coil in the pericardial space has been done, even in a newborn, in severe situations. For the standard transvenous or approach, you have to be at least, say, 40 pounds, 20 kilograms, and that's still pretty small, and about 30 kilograms for the subcutaneous ICD. Again, those are probably the lower weight limits.
Okay, thank you.
Sure.
Part of that same question from the same individual is, can you get a home version, which I am assuming is an AED, and use it on an infant? Okay,
so there, it'll say on the AED, not for use in children under 8. But if you have an infant who is having ventricular fibrillation, I would use it. I have a patient story, a true story, of someone we sent home with an AED, and they were an infant. They were less than a year old, and you can hear the 911 call because they're all recorded, and they're calling 911. My baby's having a cardiac arrest, and I have an AED, and you hear the 911 responder saying, "Don't use it, she's too young." The mom used it anyway and shocked her daughter out of ventricular fibrillation, probably a life-saving shock. And then she came in and got her implanted defibrillator after that. It was an amazing story, and she clearly needed the AED shock and got it. There are AEDs that have pediatric pads, the smaller pads with smaller energy output. And I think, like I said, the FDA recommendations are not for use under age 8 for the adult pads, but if that's all you have, there's not much downside of shocking someone who's in ventricular fibrillation. The devices won't shock them if they're not in a shockable rhythm. So put the pads on, the pads will tell you shock or no shock. I don't see, I think it's still better than just leaving them in ventricular fibrillation, even though that goes against the FDA guidelines.
Got it. Is there a scenario where you might consider not replacing an ICD in an asymptomatic patient, just removing the old one?
Yep, we've done it, and it makes me uncomfortable. But sometimes people get ICDs for the wrong reasons. Some patients will get ICDs when they didn't meet those indications. Maybe they were in that red box on those guidelines I showed earlier, but they went to a physician or a provider who either for some reason thought that you needed an ICD, and you've had it in for 8 years or 10 years. I've taken them out. I've done it as recently as this month. You have to make sure, with monitoring that they're not having an arrhythmia, they're not having a risk of arrhythmia, and that's the right decision. And there's some patients I know that others, including Dr. Ackerman, have reported on inappropriate ICDs because they got misdiagnosed, diagnostic miscues, I think he calls it. Patients who were misdiagnosed with long QT and then overtreated with an ICD. That's sort of the clearest example of someone who should get their ICD removed at the time that they don't need it anymore.
Okay. This is somewhat related. I'm curious to know if there's a target date for fully leadless pacing systems that communicate with ICDs for those of us with lead-related complications and the need for ATP or bradycardia pacing.
Great question. I don't know the target date. I know they are in clinical trials. Several of the companies have them in the works. And so the technology is there, but they're not out yet. I would guess within 2 years, but I don't know the target date.
Okay, thank you. Are leads made to be stronger and last longer now?
For sure. Good. Yes. In the 90s, and there was a lot of lead fractures. There's much fewer lead fractures over this in the 21st century. Leads are more reliable from really all the manufacturers. There's been less recalls or manufacturers' advisories. They still come out for specific leads or specific lots of leads, but they're far more reliable and seem to be lasting longer. And so lead extraction is becoming less common for that indication, for the indication of a broken lead.
Let's see, what are the different brands of ICD? What is used to determine which brand a patient gets?
Okay, well, there's multiple brands. There's three US companies, three major US companies, and several other European companies that can sell devices in the US. I have no bias for or against any of the companies. And so the decision making may be provider, who the person who's putting in it or the person that's following up, their comfort with the programming or the programmer of the device. There's sometimes certain features on devices from one manufacturer versus another that have advantages in the programming settings or maybe the shape or size of the device. They're all pretty reliable, and they all do the basic things, which is pace and shock and monitor. So I think in terms of manufacturer specific things, that, there's some devices that are compatible with MRI, whereas others are not. But all of the companies now have devices that you can use within MRI. Those are some of the features. Some of the atrial arrhythmia detection and distinguishing atrial from ventricular arrhythmias differ slightly between manufacturers. I'm trying not to use any brand names specifically.
Understand. Okay, thank you. Let's see. Andy asked, and I think he was talking about the future generations of batteries. Will they still have the same amount of energy, and is any way to make it less painful?
Yeah, I wish. So when it was looked at, there were some devices out looking at shocking with low energy for atrial fibrillation and even patient-delivered shocks. There was a couple of models that were out where you could actually, when you knew you were in atrial fibrillation, to get a low energy shock. It turned out to still be painful. So then we tried, the global we, not me specifically, we tried programming it to shock at 4 a.m. and taking maybe a sedative or a tranquilizer that night, knowing you were going to get shocked at 4 a.m. so you could take a sleeping pill and be in deep sleep and get shocked then with a low energy shock, a few 5 joules or something instead of 40 joules. It turned out that 5 joules hurt just as much as 40 joules. And you really have to get to about 1 joule for it to be tolerable. And right now, 1 joule isn't enough to get you out of ventricular fibrillation. So unfortunately, yeah, it still hurts, even if you lower the energy.
Sorry, Andy.
However, so, what we do to try to go around that is to avoid a shock, right? Let people be in their arrhythmia for longer so that it either gives them a chance to come out of it on their own or to pass out and get shocked after you've lost consciousness. That sounds a little scary, but it doesn't hurt. It's fine as long as you're not driving or up in a ladder or something like that.
Okay, thank you. Will the EV ICD be appropriate for those with SADS conditions?
For some, again, right now, unless it's synced with pacemaker, it's going to be appropriate for people who don't need pacing. And so that's the vast majority of people with SADS conditions. Now, some have low heart rates either because of the diagnosis. Some of the patients with low QT have a slow heart rate, and some have a slow heart rate because of the medications they're on, the high dose beta blockers. And so those people may benefit from pacing, and therefore the extravascular defibrillators right now don't have permanent atrial pacing capability.
What determines if someone should have an ILR implanted loop recorder versus wearing an external monitor?
Yeah, the main advantage, if you can do it without doing an implant, obviously that's better. So I would say start with an external monitor. They can last a couple of weeks at a time. There's some that last a month at a time. You can renew them. And so the external monitors you can wear, maybe 2 months. And if you haven't caught it then, the insertable loop recorders, the nice part about those is they can be in there for years, 2 to 3 years. And so if you have infrequent episodes, it's going to be harder to catch with a 2-week monitor or 4-week monitor. And the insertable loop recorders will catch those short episodes or infrequent episodes.
Okay, thank you. How is the pacing rate determined for a patient?
That really varies based on the age and the diagnosis. The goal is only pace if you need to pace. And so if you have a condition where you don't need pacing, we usually set it at 40 or something like that so that they don't pace unless they get really slow. And there's some inherited diseases where pacing is helpful. Atrial pacing may help prevent the arrhythmia, and in those people, we may set the pacing rate higher, 70 or 80, so that they're paced all the time. And then, and there's the in-betweens. Pacing the atrium doesn't seem to be harmful to the heart other than using the battery. Pacing the ventricle, we try to avoid ventricular pacing if they don't need it. So if you have normal AV conduction, if you don't have heart block, then use your own intrinsic electrical system whenever possible.
Makes sense. Okay, a question from Aaron. What exactly are the disadvantages of abandoning a lead?
Okay, the main disadvantages are infection. You're leaving a foreign body in the vascular system, so that if that lead gets infected, that infection can go to the heart valves and cause endocarditis. The leads can break, and the main one is that it scars down. The longer it's in, the harder it is to get out, and so it's just eventually, when it comes out, it's going to be harder to get out if you leave it in for another 10 years or so. Maybe technology for extraction will be better, and that'll cancel out that disadvantage.
Okay, a question from Amy. Is it necessary to discuss the ICD need at every replacement?
If you haven't been shocked in 10 years, then it's a good discussion. If you use the ICD, then it's sort of a no-brainer that you still need it. Or even if you don't get shocked, if it's detecting ventricular arrhythmias, even if they're short enough to not be shocked, you have a continued risk of needing it. If not, I think it's a reasonable discussion. This whole shared decision-making between the patient, the family, and the provider is important, because it's part of you. You're part of that decision-making.
When do you decide to abandon the leads, and when do you decide to extract?
Yeah, the only time I will abandon the leads are if it's one lead, it's not infected. That's really about it. Sometimes, so if I want to add, let's say they had a pacemaker, now they need a defibrillator, for example. That's one example, and maybe we would just add the leads next to that one non-functional lead. Some of the sicker patients that might be at higher risk, if they have a bleeding disorder or on anti-coagulants, there's a higher risk with extraction. And so those situations, like I also, same as the same answer to the last one, I have a discussion with the family and shared decision-making, sharing the risk. There's a risk of leaving it in, and there's a risk of taking it out. The risk of taking it out is at the procedure. It's an acute risk. It's an upfront risk, and the risk of leaving it in is accrued over time.
Thank you. That makes sense. Is there a way in the future to have physicians access data without the device clinic or nurse? An example, say in the emergency departments.
I would think so. There isn't now. There are programs that I've seen where people carry around a little USB stick that has their device information, or a card that goes in, an electronic card that goes in their wallet, and that card can get plugged into a USB port. I've seen that. That's, and not just for their, it gives their whole, basically their medical history, a picture of their EKG or echo or whatever is pertinent to their condition. And I've seen several different companies that have done that. I don't know that there's still that they're in widespread use. But it seems like a good idea. Keep your medical record in your wallet, or on your phone would be, right? Would be the most obvious. Everybody's got their phone with them.
Telehealth, yes. app. Well, thank you. I think that concludes most of our questions that I've seen. And I appreciate your help, Dr. Berul, in addressing all those kind of a firing squad kind of questions.
Yeah, a lot of
coming
them.
at you. There were quite a bit. So thank you very much for that informative. I loved your presentation.
Thank you.